Okay, I think we are live. A little spine here. Fantastic. Okay. Lovely, guys. Just while the live stream is populating, I'm going to be live with you guys for probably about an hour today. Again, this is your opportunity. If you guys need help, just sorting out the cameras. If you guys need help with your lower back, sciatica, herniated discs, whatever it may be, guys, if you're working through the program, if you're stuck somewhere, if you've got any questions about anything, please do post them in the comments as we approach Christmas. We're just here to help this week. We're going to be live today and on Christmas Eve. I'm going to be talking today a little bit about measuring and moving the spine to help you guys understand something I talk about all the time in terms of focus on spinal stability versus spinal bending and twisting. And we're kind of going to give you guys a bit of a sneak peek as to what we're going to be talking about on Wednesday as well with regards to going through some x-rays. Because earlier this week, or last week, sorry, one of the members shared their flexion extension x-rays with us in the group. And just going through the analysis, we see certain things time and time again. And this can help you guys appreciate why we say what we do around the spine, why we shouldn't be doing bending and twisting exercises, why they don't build us any recovery, and what we should be doing instead. And just as you guys are coming in, if you want to post any questions down in the comments, I will get to that shortly. I'm going to kick things off a little bit more steadily today, guys. Just looking at some of the comments as they come in over on TikTok. I've got lower disc bulges with lots of pain in one leg. Can anyone help? And this comment here is very similar to what so many of you guys are going to be experiencing. You've got an injury down here, L4-5. L5-S1, the two most common areas of the lumbar spine to be injured. And you've got some significant pain down there, maybe in the lower back, maybe going down the leg. And so often we focus on the pain, understandably so, because the pain is the thing that motivates us to do anything about it. But actually we need to focus on the injury that is there, providing stability for this area, doing our best through things like the towel decompression, some lower body decompression on the bed, for example, some lower body stretching to ease the tension that's coming from the hips into the lower back so this area can go through a recovery process so that we can continue on our rehabilitation work. Megs has said, I legitimately can't walk for more than 5 minutes. There's nothing on MRI. And what I would say, unfortunately so, for people like Megs that has had this kind of experience, an MRI only has nothing on it if you guys have, or if they haven't opened the MRI. There's always something to talk about on an MRI, right? What often that means is that the clinician or the GP, whoever's reading it, has said, there's nothing significant here in their eyes, right? You might be honest, often that will be followed up with there's some normal wear and tear at L5-S1. L5-S1 or L4-5 is a little bit grayed out, but that's not significant to explain the amount of pain you're in. And it's like, hold up a second, who are you to say whether that's significant enough damage to experience pain? Because you see people with all manner of MRIs. Often, some of you guys will get this scenario where you go, goodness me, I'm surprised you weren't in more pain with this particular herniated disc or whatever the case may be. And so just take a step back. We can have minor findings on an MRI or very low significance findings on MRI and still have an injury. It's just a minor one. Equally, we can have very significant MRI findings. I've told you guys before about the single case that I saw, because clinically you wouldn't see a grade 4 spondylolisthesis, right? Where the guy just walked in with a history of backache that was quite significant, and he thought he'd get himself checked out, and all of a sudden you find that this L5, his whole spine is resting in front of the sacrum. Not particularly a candidate for the first intervention to be a conservative one. You need to go and get a spinal surgeon's opinion on the structural integrity of what's going on here. So it's important to understand, some of you guys get disheartened when you get told there's not that much on an MRI. Right? That's a good thing. It's frustrating that you're in a lot of pain, but it's a good thing that there's not that much significant change on the MRI. What else have we got here on TikTok comments? And guys, those of you on YouTube, post anything in the comments. I'm keeping an eye on both areas. Is it normal to feel weak in one leg, in the left leg for L5-S1, with the weakness go away after rehab? As you progress through the rehab, the symptoms that you have, which would include weakness, numbness, tingling, burning, stiffness, aching, those symptoms go. Do you get to choose which ones go first? No, unfortunately not. A common scenario for those of you with sciatica, so that's symptoms going down into the leg, we could say. Lumbogenic leg symptoms, so an injury down here in the lower back that is sending signals down into the leg, is that you get this process of centralization, meaning that the symptoms recede back up and focus in the lumbar spine, and then that goes last. That's a very common occurrence for those of you guys with lower back injuries. It's not always, sometimes it just settles. Generally speaking, what we think of as worsening And you see this play out in the clinical environment all the time. People say, I had back pain for a long time, and then I had another episode and it started going down my leg, right? That's often something that we would classify as being worsening, right? It's worse if it starts in the lower back and then starts to go down the leg. Does that mean something's spreading? No. It just means that the injury here is hitting just the right kind of nerves that then go down the leg. Think of your sciatica no different, fundamentally anyway, in terms of sensation, as the funny bone just in here. If you bang it, you get symptoms in your fingers, right? It goes tingly, it goes pins and needles, etc. because you banged here. When you bang certain nerves here, irritate certain nerves here, we can get symptoms that go down the leg. So it's no different. Now, in the case of the funny bone, we just don't bang our elbow again. But in the case of our lower back, we're constantly often irritating that lower back. What's more is we often think the problem is in our leg, so we spend a significant amount of time, unfortunately, focusing on the leg rather than the lower back. Lincoln has said, in a nutshell, can you help me with recovery from a laminectomy from my L3-4 segment? Yes, focusing on spine stability work to provide stability to this section of the lumbar spine. That is what's going to help you from a recovery point of view. That's what we go through in the program. So that would be, you'd be a candidate. Typically speaking, L3-4 is slightly less common than L4-5 and L5-S1 in terms of the prevalence in back injuries, but it's necessary in your case. And the stuff that we talk about, spine stability, applies to all that section of the spine. What can we do? Why do we talk about spine stability so much? Because you can't control, as I'll talk about shortly, you can't control what's happening in the individual segments of this section of the spine, as we will see later today, or we'll talk about later today, and we will see on Wednesday. You can't. So all you can do is brace this section between the bottom of your rib cage and the top of your pelvis, which includes, by the way, the SIJs and the lumbar spine. You can brace that area or you can not brace that area. It's up to you, right? Jackson has said, I have another back extension question. Don't worry. These questions are helpful, Jackson, and I'm sure many others that are watching have the same sort of questions, so don't feel bad at all. When I was doing the back extension, I would feel a pump when doing the reps, whereas when I do the hip hinge, I don't. Does this matter? Should I increase the weight? I think I mentioned last session, when you do the hip hinge, and the best answer to this question comes from that question next to the video of you doing the hip hinges specifically, because then I'll be able to see, right? So when a lot of you guys start your back injury rehab, you're rehabilitating this section of the lower back, you are in a difficult position, let's say. And so you might start with your hip hinges only going to here. I don't know exactly where we're at, Jackson, but if you're doing your hip hinges to here, that's probably not the same angle that the back extension machine started at. This is what I touched on Friday, guys. The back extension machine, which is this one here, right on the floor, it's just out of shot, starts at about 45 degrees angles. So you're already in a harder position than you've started the rehab on. So Jackson, you will get that pump in the lower back. You're just carefully approaching it. Get some videos into the members area. Let us see where your hip hinge is at. And you probably need to move through into phase 2 and then phase 3 a little bit sooner. But you will certainly feel that back pump, tension in this area here, subsequent to doing your hip hinges when you start doing them at the right level. And for others that don't have the experience of working out, maybe that Jackson has, and that many of you have, that feeling of a tension and aching in the lower back after doing the hip hinges or the squats actually really puts you guys off. It makes you guys feel nervous. It makes you guys feel uncomfortable. But it is actually a perfectly normal process. It's a perfectly normal process. What else have we got here? Meg says, yes, 100% normal wear and tear. Legit, I have spinal stenosis symptoms. Yeah, so normal wear and tear is not an answer, right? Because what will happen, Megs, is if you dig down into the report, you'll find that the wear and tear is probably focused around about L4-5 or L5-S1, the lower sections of the lumbar spine. Why? I know sometimes you guys are like, oh, well, everything Mike says is about L5-S1 or L4-5. Those are the areas that most commonly are injured. And judging by the comments, any of you guys that have joined us for a number of these lives, everyone comes in, my injury is at L4-5, L5-S1. Yes, we had the L3-4 laminectomy up here, but most of you guys, and I can see there's another comment from Jimbo talking about a degenerative disc at L5-S1, right? Megs, you'll get these kind of comments, say wear and tear. Well, ask the question, why is this area so much older than everything else? And that's why seeing the images is so helpful. I'm reticent to suggest, to make you guys reliant on images, and at the same time, sometimes the things that I say might lead you to believe that I discourage you from images. But images are a fantastic educational tool to help you guys understand. And Megs would see very clearly, if she looked at her MRI, I strongly suspect, a notable difference in one of the segments, let's just say the L5-S1, because it's so common, in its visual appearance compared to others. Now, it might not be significantly bulged or herniated, fantastic, but there is some issue there. that there's not at other segments. And so we understand, fantastic, thank you. It's not a significant injury, but it's an injury nonetheless, and it's an injury that's significantly affecting Meg's quality of life, as it is for many others. So we set about the rehabilitation. We set about the rehabilitation work. Very Pog has said, what situation if you trained regularly before your herniation? Your core and back muscles are regularly trained. A lot of people train regularly that don't necessarily have the best habits, right? And that's something to bear in mind. The question is, what were we doing in our regular training? How good are we at the technique? Equally, we have some of the members that are into CrossFit and other sorts of activities. Some of the ways in which you use your body in those sorts of scenarios where you're pushing yourself creates habits that work before you're injured. Once you're injured, those little habits that you're not even aware that you're doing are actually holding you back. So that's something else to consider. When you think about those of you guys that are previously trained, some of those little errors need to be fixed, and that's why recording yourself is so powerful. For example, one of the common ones, right? When we're doing the squats, I won't bother grabbing a bar, but when we're doing the squats, we do the little butt wink at the bottom, okay? And many of you guys, when you're doing other movements, you do like a hip thrust through, or we'll do a pelvic tilt. Those kind of movements, they're subconscious. You're not even almost aware that you're actually doing those kind of movements, but they are getting in the way of the recovery process. Jimbo says, I have a degenerative disc at L5S1. Is an injection my best option? Injection for what? What does the injection do? When we have a degenerative disc, understand you have a degenerative disc, but what does that mean? It means the soft tissues and the hard tissues at that level, often, have been degraded. They're less healthy. And so you injure them more readily, I would argue. And so an injection doesn't do anything to build up the strength and stability of that area. An injection may well calm down the inflammation there, but you need to do the rehabilitation work to rebuild strength and resilience at that level. Help the area stabilize. Help the soft tissues adapt to maybe the changing architecture. Realize that if it's significantly dropped like this one is, you're not going to have the same degree of motion at that particular level. And so spine stability is so important in helping you rebuild the strength and adapting to the lay of the land in terms of the architecture. If we've lost material from a significant herniation change, then we're not going to get that disc popping back up again. So it's a little bit smaller, so the facets are a little bit closer, so it won't move as well that long term. Does that need to be a problem for the long term? No. But it does need to be considered, and then we need to do the rehab work. Very important. What else have we got through here? Okay, coming over to YouTube again. Hi sir, I'm a member of the program but slacked off. A little based on various different feedback from physios, chiro, osteos, etc. I've come back to basics after doing the phase 1 again. Nice work. Everybody does that. Everybody does that. I haven't done a consultation call. Do you think it's still worthwhile? I feel the program is good and will help me long term. Perhaps I've lost time by doing things, 2 slip discs, L4, L5, L5S1. The most important thing is you do the work, right? Do the work. The core, one of the things that we've always said to members about joining the program and the utilization of a consultation call, it's a waste of time if you haven't done any work. And what I mean by that is us rehashing your previous symptoms. It doesn't help. It doesn't help the conversation. It doesn't help moving forwards. What helps is you've actually been through some of the material, because the question I go is, that's fine. You could do 15 different things. Those are kind of, they're useless in a strategy point of view going forwards. It's helpful to know you want to get back into martial arts, or you want to get back into X, Y, Z. Those goals are helpful, right? But they don't help us from a point of view of doing the doing. What's really helpful is when you guys have had a chance to really work through the program, to get in, dig into the exercises, to watch the tutorials, to do all of that work, then you've got a baseline level of knowledge, a baseline level of experience, and you've done that work at home already, and then you're struggling on a few key areas within the program. That's when having a conversation can be helpful. That's when talking about things can be helpful. But what we've found over the years is actually members feel like they need to have a consultation input less and less frequently, because these little touch points along the way actually work so much better. You do some videos, you do some exercises, you record yourself doing those, then you get some feedback, and then you modify things, and then you do some more work, and then you modify things. Often with a long conversation, there's not necessarily as much of the answers, much of the do this, do that is, okay, now you need to go and test this, now you need to go and test that, now you need to try the tape test, now you need to do things, because that's how we get new information so we can move forwards. So that's something worth bearing in mind. Get stuck in, Zabe, get stuck into the tutorials, to the strategy material. If you're coming in and you haven't been with us since before September, definitely get stuck into the core phase 1, 2, 3, strategy material, work your way through the program and lean on us in the members area for support to guide you through the process. That's the best way to go forwards. Looking through some of the comments over here as well. I think the program is great. I trust the outcome. Question, how often do I do the lives? So LM has asked here. So by lives, LM, I think you're referencing the live workouts, and there's always been some back and forth as to the verbiage of those. I think maybe the best way of thinking about them are follow along workouts, because you're following along with them. Why? Because we want you to do the same workout every time, or the same selection of workouts, because that allows you to measure your progress. If you're always doing different things at different paces, right? If, for example, we're doing 5 sets of squats and we give ourselves an hour between each set, we're going to come to them very different in terms of our freshness. If we're always giving ourselves 90 seconds to complete the set and go again, then we've got that standardization across the sessions. So when we start out in phase 1 and phase 2, for most people, you're doing the workouts every day, once a day. And you're doing the core relief work around that. So that's our rehab work is done once a day intentionally, and then with a proper follow along live workout. And then our relief based work is done scattered through the day. Those little routines you've got, the 10-minute routine, 12, 15-minute routines that are just there to decompress the spine, ease the congestion, help mobilize the hips a little bit. You do those regularly through the day. And then as you get into phase 3 and phase 4, at that point, it becomes necessary to start to spread things out a little bit. We might have rest days interspersed with our workouts each week. We might have what we call active recovery sessions, which are lower intensity sessions. That's the way it can go over the sort of the medium to long term. So it changes. And again, that's one of the reasons why we have support, because as you go through the process, different people need to switch over to start incorporating rest days for different reasons at different times in the process. So that's something worth bearing in mind. Hopefully that helps, LM. Thanks for the question. A series of numbers has said, I work where I constantly have to bend down. My mid and lower back hurts the worst. How do I fix it? Guys, if you demand more of your body, you have to be better conditioned, right? It's difficult when you're trying to do that when you've got an injury, but that's the option. You have to make sure you're learning to bend correctly, right? Bend with your hips, knees, and ankles. Often people are just bending with their lower back. And you need to build a resilience, right? That makes life easier. As you get stronger, daily activities, our working activities, become relatively a lot easier. And so they are taxing us less, therefore we are less likely to be overwhelmed, either in a repetitive nature or in a singular nature, from the work that we're doing every single day. KG50 said, I had a discectomy over 2.5 years ago. Now I have small protrusions at L5 and irritation of the nerve. We see this unfortunately too frequently, guys. You guys have had some sort of microdiscectomy, maybe in the case of the previous question, we've had a laminectomy or something else like that, and we don't get given the proper rehab. And maybe it, quote unquote, works. I mean, at the end of the day, you've had the disc removed. That was the objective of the surgery, right? So it's worked, right? But we never rebuild strength and capacity into those sections of the spine. So we often find that either the same segment becomes re-injured, or the segment above, the adjacent segment, becomes the segment that becomes injured. All too often we have an L5S1 operation, and then a couple years later, a couple months later, L45 starts to go. Why? Because the same factors that prevented the L5S1 from healing on its own are still present. And because we've removed so much of the disc, it's more likely that the segment above is going to be strained on a regular basis. Very, very common to see that, this ascending issue or descending issue, depending on where exactly the surgery is. But commonly, L45 and L5S1, those two guys, they should be moving quite a bit in the lumbar spine. And so when one fails, the other one's going to often take extra strain. And if we're not, that's why spine stability work as a means of rebuilding resilience into that section of the lower back is so powerful. Zabe has asked, I would go back and reflect on some of these questions, Zabe. I'm just scanning through this. Can I do upper body machine workout right after a live follow-on workout that I do in the gym, or is this not suggested? I'm around 70% pain-free through the McGill Big 3, but now need the next improvement cycle. Focus on the program. Focus on the program. It's not about how you feel. It's not about how you feel. Too many people make that mistake. It's about objective measures of your back's resilience. That is done within the workout. If you're still messing around with a 5, 10, 15, 20 kilo weight, and you're worried about doing other areas of the body, forget about it. Focus on doing spine stability work, building strength and resilience, and getting to some good loads on things like the squats and hip hinges, and then start worrying about doing your upper body in your other areas. All it does is add variables. Will many of you get away with adding in your upper body work? Sure, right? But it's an additional variable that you need to think about. If you're there sat down, if you're sat down, this is obviously not the right chair to do it with, but you're thinking about, oh, I'll go and do some incline dumbbells. That doesn't hurt my lower back because I'm lying down, right? You're there, or you maybe can do some shoulder press, right? You boom, boom, you kick it up, you're doing your shoulder press like so, right? That's 5s in each hand, but maybe you had 15 kilos in each hand. And you've got that loading going through your lumbar spine. 30 kilos of loading going through your lumbar spine whilst you sat down. And all the movements involved to get in and out of that position. Like, these are extra things you don't need to worry about. Focus on the building of the resilience, on the simple stuff. We talk about this very specifically in phase 4. You guys want to build resilience on your main workouts. Make progress on those main workouts, and then you can start to branch out to incorporate, as we mentioned, those additional workouts that we talk about. Reasonably safe bets when it comes to extra exercises to add in at the right time. But you've got to not go on how you feel. Go on objective measures of your lumbar spine's strength and load tolerance. And that is what you're doing on your squat and your hip hinges. Zabe said, my remaining pain is more nerve pain I feel when I wake through my right leg. I'm doing the work and feeling better, and we'll continue doing this. Focus on the rehab work. Focus on the rehab work. That's the best option. Like, going on how you feel is not appropriate. It's not an appropriate measurement tool. It is a measurement tool that you will use because that's often the one that you care about most. But as it pertains to using your progress as a means to evaluate what you're capable of doing in the real world, how you feel does not matter at all, right? If you're struggling to control 5 or 10 kilos of load on a squat or hip hinge, that holiday you're going to go on where you're going to carry the 20 kilo bag or suitcase down the stairs or off the bed or into the car, like, how you feel is irrelevant. If you're struggling with the 5 to 10 kilos of weight that's nice and compact and ergonomic to use, the big suitcase that you're going to have to carry is a risk. And at least you're aware of that, right? You might still go on holiday in that scenario, but you've got to be aware of these things. And so that's why it's so much better to focus on how you're actually performing the exercises. They have many benefits. It's not just exercises for exercise's sake when it comes to your rehab. It needs to transfer across to real world scenarios. In the real world, your back is bearing load. It's always frustrating when you get people saying, oh, my surgeon said I shouldn't do squats. It's like, that's fine. How did you get out of the chair after the conversation with the surgeon? Did you do a squat perhaps? I hope they corrected you and told you not to do that again. You know, it's silliness really, some of these things. The arguments become a little bit nonsensical. Becky said, touching on the topic of degeneration, so it's not the end. By doing rehab, I can improve the disc. Depending on the degree of degenerative change, you might not be able, well, you won't be able to make a disc that's lost 20, 30, 40% of its height pop back up again. But objectively, you will be able to tell, Becky, I suspect right now, that your disc cannot bear the load of 5 kilos, picking up the dog, whatever it may be, right? And then in 6 months' time, if you go through the rehabilitation properly, carefully, and progressively, you will be able to pick up 20, 30, 40 kilos and so on. Thereby verifying that that disc, although it might still look degenerate on an MRI, you've halted the process and you've rebuilt strength and resilience into that particular section of the spine. It's not like you're bypassing load. Sometimes people make the false understanding of, oh, by building up my muscles, the muscles are taking load. No, right? The muscles are not rerouting the load going through your spine. They're just supporting the spine better. They're accounting for some of the variables, some of the injuries, some of the changes that might be taking place, depending on the degree to which that disc has dropped in height. In Becky's case, it might well not have even dropped in height that much at all, if at all. It's just showing signs of degenerative change, a minor, as opposed to the complete collapse. We see this on, and this is why it's so helpful when members upload their images to the group, because we've got members uploading their x-rays, their MRIs, their CT scans, and you see, oh, John's got some degenerative change on his x-ray or his MRI, and I've got some degenerative change at the same second mine, but they don't look the same. John's MRI or x-ray is very different to mine in terms of the space that's left. And that's why comparison is quite important. Even within your own spine, you can compare it to different levels to see the kind of change that has taken place. Whenever we would go through and do go through images, as we will do on Wednesday, we're going to go through these flexion extension x-rays, right? We always have a normal there, so you guys know what you're looking at, because you're not looking at these things every day. I go back to when I remember first looking at x-rays, and sometimes you feel a little bit like it's just a series of clouds, right? Like trying to pick out things in clouds, and you forget that. But seeing the normal is really important so you can compare and contrast to understand things better. What else have we got in here? Just looking back through some of these comments here. And guys, I'm going to be with you guys till around about 1 o'clock, so you can keep throwing these comments into the comment section and we'll keep it going. Hopefully it's helpful for you guys. Alan says, I thought every day phase 1 with relief exercises later sounds good. Awesome. Glad you got that right. And guys, the strategy material in phase 1, 2, 3, and 4 and in the core relief work, always revisit it, right? Especially that last video on each of the strategies, when to move on to the next phase. A very important one. Rapunzel said, when I'm lying flat on the floor, I feel like my lower back is hard and protruding out painfully. Not too sure what to make of that. The sensations that many different people experience when they lie down on the floor, on your back, on your front, whatever it may be, we get too caught up in sensations. Once you've validated that there is an injury there, resign yourself to the reality that everybody's going to have different sensations in these sorts of scenarios. You don't control these nerves, they look like, oh, it's just one little nerve, but it's carrying tons and tons of different nerves, carrying different information in both directions, up to the brain and down to the body. You don't know which one of these has been irritated, right? You don't know. No one can know really, they can just see that it's poking a nerve, because we're looking at a very small level here. You'll see all of you guys showing all sorts of different symptoms as a result of your varying injuries. They all tend to be focused around the L4-5 and L5-S1 segment of the lumbar spine. Some people just noticed the first time, when was the last time before you injured your back that you were laid on a hard floor and you realize, actually, it's not that comfortable, right? My SIJ, these bits are bony, right? When you lie on them, it can be a bit uncomfortable on a hard floor. So use a mat. Use a mat in that scenario for your exercises. But many of you will need to start your rehab work on the bed because it's a little bit more comfortable and it's easier to get up from. Tiki has said, I've got compressed L4-5. Can you show me on the model exactly where that is? That L4-5 is the green one here and the green one here. This is L4, right? So the lumbar is the green part of the spine here. That's the area that we're most interested in, guys. The orange is the sacrum, right? And so what we should have, if I show you guys on the other model in a second, but we should have a smooth elliptical curve through the lumbar spine. There should be more curve at the lower part of the lumbar spine and less curve at the bottom as it translates into the thoracic spine, which is in blue here, sometimes called the dorsal spine. And then obviously it goes back into a backward bending curve at the cervical spine. This is in me like this, okay? And so what we've got in the big model, which doesn't have the colors on, I'm afraid, is we've got that sacrum, which curves forwards, right? Into the lumbar spine, which curves backwards, into the thoracic spine, which curves forwards, into the neck, which curves backwards again. And so L4-5 is arguably, maybe we could say the last, or the second to last mobile segment of the lumbar spine, and then we get this transitional segment, which is the lumbar L5 into the sacrum. And there are various individuals that might have congenital abnormalities at these levels, termed sacralization, lumbaralization. Sometimes the term Bertolotti syndrome is thrown about because of these asymmetries. But they are atypical, they're not ordinary. But that's where it is, right? Very, very common. L4-5 and L5-S1, the last two segments of the lumbar spine here, this one, and this one. That section is the section that most of you guys have injured in your lower back. How much does our state of mind affect our body? A state of mind affect our body? I say very often, the man who thinks he can and the man who thinks he can't are usually both right. And if you are struggling with lower back pain, you've been told it's all in your head, there's nothing wrong in your back, maybe to some of the comments earlier, it can really set you back up here. And especially if your back's failed you so many times for what feels like no apparent reason. When you start to realize that actually, this is why the spine stability stuff is so good, why I harp on about it all the time, because it's accessible to everybody. You can all do the test, right? You can all see if you could do a squat or hip hinge, right? And then you can realize that you're not very good at them and that you aggravate your lower back. And you realize that, oh man, if I can't even do this exercise where I'm actually trying to protect my spine and do it correctly, is it any wonder I'm struggling? And that, although it's a negative in the first instance, when you take a step back and look at it, it's actually a positive. Because for the first time in a while, you realize you've got something that you can do to improve something that actually is quite a poor measure, right? You can improve the ability to perform the squat. No one else does that for you. You do that. And then as you start to make progress and you look back at videos of what you were doing a week ago, 2 weeks ago, 4 weeks ago, 6 weeks ago, and you see the progress, that builds confidence. And then when you start picking up a 5, a 10, a 15, or 20 kilos, what you thought, we get it all the time, what you thought was not going to be possible 6 weeks ago, you're now doing. And the evidence starts to become overwhelming, and that builds confidence. Just being told it's all in your head, you're actually fine, go and do that stuff, is not helpful. It's just patronizing and wrong. But if you've got a plan and you follow it and you record yourself as you're doing it, you will see the results start to kick in and you will feel better for it up here. And then the more you do, the more you feel you can do. So you make progress faster. And what was a downward spiral starts to become a positive spiral in a very good way. Jamie said here, hi Michael, I had an L5S1 herniation with sciatica down the right leg in February. Found your YouTube in August and I'm doing the rehab. Awesome. My sciatica is gone and I'm proving, oh, okay, cool. That's really cool, right? My sciatica is gone and I'm moving freely now, so thank you. I think I might be able to post it. Oh, look at that. There we go. There's Jamie's comment. That's cool. Right? Thanks for sharing, Jamie. That's really cool, right? If you do the work, it doesn't happen overnight. Those of you on YouTube will have seen that. Let me know, guys, if you saw that, if you actually saw that. I think that came out. Just testing some of the features. But Jamie, thank you for sharing. Or Jai, that might be Jai. Jai, sorry. Trying to do too many things at once. Brad says, hi Mike, I'm not healed 99%, but there is still a very slight pain in the glute that never completely subsides. Am I irritating it with my exercise or habits, or is something that will always stay? One of the things with these back issues is, like I mentioned earlier, you don't get to choose which bits go first. And when we're in so much pain in the first instances, it's very easy to focus on that, and then as that goes, like, oh, euphoric, right? We're not experiencing pain every moment of every day anymore, and we're feeling a lot less vulnerable. But the little things that often remain, such as this, such as a bit of numbness in my big toe, or a bit of tingling in the shin, that's just there as residual. It's not there all. It's not there. If I start doing things, I kind of forget about it, but it's still there in the quiet. And some of those things, they take the longest to go. So ask ourselves the question, Brad. That's why we always talk about these objective figures, right? Because Brad feels 99% healed, which is fantastic. But how strong is Brad at this stage? What else is left to do? Where else can we make improvements? So let's look at the load we're doing on the squats and hip hinges, right? Have we got up to the 20% mark of our body weight? Have we got up to the 45% mark of our body weight? Have we got up to the 75% mark of our body weight? Have we hit the 100% mark of our body weight aggravation-free with correct choreography? And if we have, where are we at with our hip mobility? Now's the time to work on hip mobility. Having a think about those key areas. And then you've got that. This is one of the features that we're going to be rolling out in the new year after the workout logging, is having this track front and center in your mind, guys. Whenever you come onto the website, onto the app, having that chart of where you are in comparison to those figures. So it becomes a little bit more real. And I would encourage all of you guys to do this right now. Get a sheet of paper or a note on your phone. Write down how much you weigh in kilograms or pounds, it doesn't matter. And then write down what 20% of that figure is, what 45% of that figure is, what 75% of that figure is, and obviously the 100% you've got it there. And then write down what you can squat or hip hinge with correct choreography and without any aggravation of your symptoms for 10 reps. And see where you stack up. For most of you, the question will be, what? You mean squats? So the answer is 0 to that question. And if the answer is 0, you have to understand those first two figures are pivotal. The 20% of your body weight and the 45% of your body weight is the extra load that goes through your lumbar spine, those injured sections, when you are sitting down. So while you're sat down watching this TikTok live or watching this YouTube live or watching the recording or watching a clip even, if this gets clipped, you're already putting more strain than you're doing in your rehab. Well, that's a problem, right? Let alone if you're carrying stuff or whatever. Let alone if you're sat there holding the baby and you've got to get out of the chair, right? We're already putting a lot more load through our lumbar spine every day. So thinking about that as a means of guiding, how healed am I? And then the question is, for what, right? What do you want to do? So hopefully that helps, Brad. Some things to think about and reflect on to measure things a little bit more effectively. What else have we got here? Jake says, I've got sciatica and boost impingement overload. A lot of muscles in my back, hips and legs. Not sure what we're saying there, but if you've got sciatica, bilateral impingement. The stuff we're talking about is relevant. When we've got it, what we want to do is, when we've been diagnosed with this sciatic issue, shift the focus. Sciatica is the symptom. we've got an injury. That's what we need to focus on. Now we stabilize, protect that injury. Then we improve competence around this area. Then we build up strength. And then we start to rehabilitate the actual spine by applying careful load to the spine. And while we're waiting to do that, while we're going through that process, we're also using relief-based strategies to take strain off that area regularly through the day. Give it a breather, so to speak. Some people get muscle cramps when I stretch my sciatica. Why is this? You're often involving your lower back. And I don't know, when I stretch with my sciatica, I don't know what stretches you're doing, guys. A lot of times you're going to be doing stretches and you're doing this kind of thing. Reaching over, you're rounding your lower back. You might be doing a hip flexor stretch and you're coming round back like this. We're doing all sorts of stretches, maybe figure 4 stretch. Look at what you are doing with your lumbar spine when you are doing the stretches. Often you are involving your lower back, which you should not do. You're trying to stretch your hips. The hips don't involve the lower back. And by moving and involving your lower back, you're just decreasing the effectiveness of the stretch on the hips. Jeff said, good workout to improve sitting on soft couches or chair. I have no problem sitting on hard chairs. The workout you need to do is the same workout. You just need to make more progress, because soft chair, you're going to slump into more and therefore exert more strain often on those segments of the lower back than if you're sitting nicely on a hard chair. My muscle and core want to engage, but I've been doing exercises for 3 months. What exercises? What exercises have we been doing? Have we been doing them correctly? Right? Have they been spine stability based exercises? These are important questions. Someone said here, I have stenosis at L2, 3, 3, and 4, including corticoquinus syndrome at L5, new herniation at L4. Any tips? You've got to focus on spine stability work, guys. Spine stability is what you use to protect that section of the lower back. That's what we need to focus on. Jackson has said, I've also noticed some popping on the lower back when I do the decompression on the bed and the seated version. I probably wouldn't bother with the seated version, Jackson. I'd probably stick to the bed decompression and the towel decompression. The pops and the clicks are often spontaneous cavitations. As you decompress the facet joints as well, because you have to, right? That's the way it works. When you do an axial decompression, the segment moves apart, right? And so that's just little bubbles popping in the joints. Exactly the same as when you crack your knuckles, or when your chiropractor or osteopath manipulates the joints. It's just creating a little decompression at the level of the facet or synovial joint. Yeah, hopefully that makes sense. Don't force it, but it should generally be painless. It should be painless. It might just be disconcerting. Some people cavitate very loudly, others a little bit more quietly, but it's not a problem. Tara said, a preemptive question, but it's always in the back of my mind. Once performing a hip hinge and squat at 75% of my body weight, aggravation free of course, and possibly not wanting to progress lifting, how do I ensure I'm not going to be in the position of injuring my back again? The one thing to bear in mind, and this is important, you can never stop yourself from catching a cold again, from breaking an arm, a limb, etc. We can just decrease the likelihood of being put in a scenario where we bite off more than we can chew. And so the best thing to do is the habits that got you there, Tara, will be protective in that regard. The tools that you've got, such as the relief work, decompressions, etc., lower body stretching, the skill that you've developed, will be there as an antidote if you do push yourself a little bit too hard. I would strongly suggest always committing to small amounts of incremental improvement, small amounts of increase over the long term. And the reason I say that is as you start to get towards that kind of level, you're going to find it more and more difficult to make progress. You're going to have to choose to spend a little bit more time on working out, right? I think it's very unlikely that I'm going to be able to get back up to the levels of squat or hip hinge that I used to do, because I just don't want to devote that much time to working out in the gym. I want to do jiu-jitsu more. The times that I got to those kind of levels was when I was training all the time. That was 100% the focus, right? And so there will get to a point where in order to make further progress, you're going to find the progress starts to slow down, and you're going to have to do some extra stuff around the resistance training mode, if you will. And you might not be willing to do that. So you keep trying to make progress steadily, and what will happen is things get in the way, right? We're going into the Christmas season, we're going to do less. We're going to come out of the Christmas season the other side, and we're going to feel like we need to slowly get back into working out, which is sensible. Me, for example, having a bit of a rough, food poisoning 2 times, the eye infection, and being on the antibiotics and everything for the last, since about halfway through November, it's been tough. I'm not as strong as I was, right? So I'm going to have to build up. But if you're always focusing on increasing, you're going to just be able to fill those gaps where you step back, and you'll get into a nice rhythm. That's the best way. That's the best thing we can do going forwards long term. And you might have accidents, you might slip, you might sprain an ankle, you might do other sorts of things, and those will be in the way of your working out. And so you'll always be, having little bumps along the road, not necessarily related to the back at all, but your workouts will always have something that's going on that might interfere with your progress from life events, holidays, colds, coughs, all these sorts of things. So for most people, I think as you get to that sort of level, just keep on trying to improve. Keep on trying to improve is the best thing I could say. But I wouldn't worry about that particular issue, especially if we're a little way off it. Roy has said, I feel weakness in the legs, but no sciatic symptoms. What is going on? Your legs might well be weak. I think a lot of people are actually very weak in the legs. Now, depending on what degree of weakness we're actually talking about, well, that might need a little bit more talking about. In particular, what else we got on here? Vicky has said, I've just had a spinal discectomy. What exercises would you recommend to start, build, and strength? So the most important thing, when we talk about building strength and stability, this is a great example because we've just come out of a surgical intervention. The way we teach you guys is to be as safe as possible. So you find, for example, we focus on spine stability work. Why? Because the whole idea is you're not moving the thing that is injured or that's just been operated on. You're protecting it, right? It's the only time of the day that Vicky will be 100% focused and directed on how to protect the segment that's just had the operation. The only time. You probably didn't get any instruction from the surgeons, which is a real shame. You probably haven't had the instructions from the physios on how to protect that area, things to think about in order to prevent it from going through unnecessary strain. And saying just walk and don't sit is not an answer. You still have to get dressed, you still have to go to the bathroom, you still have to answer the door, etc., etc., etc. And so we teach you guys in the program, phase 1, you're not using load. A squat might be something like that. You're doing what you can do without aggravation that is technically correct and sound. That is your focus in phase 1. That's what we should be learning right now, right? Because again, the things that Vicky will be doing, even the travel from the hospital to get home, will have involved more precarious and peculiar movements that might be performed carefully within the context of proper rehabilitation. Note, we are not saying doing anything like knee hugs or rocks and twists, right? Or child's poses or any of that kind of stuff. We're talking about stabilizing and protecting the area that has just been operated on. Once you've got that foundation, you can then start to carefully apply load. And to start with, we talk about in phase 2, just applying a token load. You're just holding something, right? Because it could just be a phone, right, that you're holding while you're doing a squat. And then in phase 3, we start talking about making some element of progress. But you might be instructed not to significantly progress on with the rehab from the surgeon for a period of time. Okay, great, fine. But compare what you are currently putting the spine through to the rehabilitation. And you could always spend that time to really hone in on your technique so that when you do get the all clear, hey, look, let's go. Let's start building some strength now. Start testing the load tolerance of that disc, of that section of the spine again. Okay, you've got some really solid foundations from a technical side of things because the technique is going to be tested at all levels, at all times for the future. Going back to Tara's question, the technique Tara had to master when she was just doing a squat with body weight will be tested when she uses 5, when 10, 15, 20, 30, 40, 50 kilos. The same errors will be tempted to occur when you do those exercises. So the technique really matters. And being aware that technique will be tested when we start challenging ourselves more is an important thing. We cannot be complacent just because we've been doing the squats. We still need to focus and develop good habits and be aware when we are starting to be challenged so we are doubly sure of actually holding everything together. For example, we might well be fine doing our squats like this. Okay, we're going good, good, good. But when we start adding load, the load can pull us forwards, right? We're doing a 20 kilo squat. The load is still got the temptation for me to round my lower back, for me to fold forwards at the lumbar spine. I still have to do the same things I had to do when I had no weight. When I had no weight on a squat, people make the mistake of doing this, right? Because they're weak and uncoordinated. That same mistake is going to happen when I'm holding the weight here. I can still do this. You guys can see my back looks like a prawn or a fishing rod. I still have to consciously think to keep my spine nice and straight as I'm going through. Right? We still have to think about those things at all levels. So if you have to delay because you've been given the guidance from your surgical team, obviously always talk to them, Vicky, and others. But you can still get technical improvement right now. What else are we going to do all day? Right? Too often, the guidance post-surgery is do some walking, don't sit down, don't twist, don't lift, and you got an appointment with your physio in 6 weeks' time. And that's it. That's not guidance. That's not support. That's not instruction. You still got to live. What else have we got here? We've got some more comments coming in. We'll continue to lift at that level. Ultraviolet said, I feel like I have been trying for months to figure out what is causing my flare-ups without much success. Am I just wasting my time and energy trying to figure it out? If you're not doing your rehab, Ultraviolet, then yes. Because for most people, it's little things. It's cumulative little things through the day. Focus on your rehab, right? If we got you into a position, especially for people that are at a certain level of chronicity, if you got you into a certain position, you might be able to get away with it once. I guarantee, almost guarantee, if we recorded you a day in the life of Ultraviolet 39, you'll be messing things up all over the place. But you get away with it. And sometimes you don't. Focus on the rehab. That's what is objective. That's what you can control. People spend too much time worrying about why they had a flare-up yesterday afternoon. Like, it's often cumulative. It's often cumulative. Well, you had to run out, go to the shops, and then you had to go and do this, and then you did that, and the dog was on a walk, and it decided to chase after a squirrel, and oh, you got pulled a little bit. It bothered you a little bit in the moment, but you didn't think it was too bad. Focus on the rehab. One of the biggest things that we talk about the rehab is it's like being in the lab. Outside variables are controlled for. Build strength and resilience. If you are so weak that you cannot pick up 20, 30 kilos, 10, 15 kilos, 5 kilos, and do some squats and hip hinges with them without aggravating your lower back, without creating irritation in the moment, then is it any wonder that you struggle to go through daily life and have flare-ups here, there, and everywhere? And so it's very difficult to actually effectively and fairly appraise daily life. Just know you're going to have flare-ups until you get stronger. And the flare-ups will get less and less the more resilient you become. And rather than spending endless hours getting frustrated, feeling like you're going in circles and tying yourself in knots, looking at that stuff, yes, you want to do the best you can. That's why we have a lot of education within the program. But focus on the rehab. Focus on the rehab. What are you not doing right in the rehab? What are you not doing wrong in those scenarios? Daryl has said, do you recommend using an inversion bench to decompress? Yes, I do think that the inversion tables, good ones, because you're hanging upside down, don't get a cheap one, are worthwhile. But they're only worthwhile if you're going to keep using them, right? If you're going to have them out, you're going to have them out available, accessible. And I think they're a really good investment for the long term, but they are a little bit more expensive, you know? We want to make sure we're getting the right one. We have tutorials on the YouTube channel, on the website, to talk about using these and give you strategy. If you buy an inversion table and do not approach the use of it the first time correctly, you're going to mess yourself up, and then you'll think that it's something that you can't benefit from, and that's a real shame. And it would be much better if when they delivered the inversion tables, because we bought the teacher table, we gave one away a couple of years ago, and my mum and dad still have one. So does my auntie, because they're good, right? But they've got to be used. It's no good buying it and then just sticking it in the corner. You've got to use it. They're reasonably heavy, so you've got to set it up and leave it set up. What else have we got in here on the comments? Someone said, what do you do if you can't move? You start where you start, right? You're lying on the bed. Are you actually moving? Have you not been to the bathroom in 3 days? We probably have, right? It's important to be accurate. You know, and I'll bring this up because I did a video on it online. Someone posted the other day, I'm 10 out of 10 pain, 24/7. And I said, that's not correct, right? That's not correct. I'm sorry. It might be bothering you a lot. It might be the worst thing you can imagine, but it's not 10 out of 10 pain. And it's really important for you guys. Sometimes it can be tempted to not appropriately communicate what we're experiencing, and that makes it really, really hard for your clinician to help you, right? When someone walks into the clinic and says, I'm in 10 out of 10 pain with a straight face, it's so difficult to move forward because it's like, no, right? If you're in 10 out of 10 pain, you are writhing around incoherent, you're not scrolling through social media, you're not posting, right? I'm not saying that's the case here, but it's important that we appropriately describe what's going on, because that helps us help you guys so much better. Right? Very, very important. Very important. Seeing Lara in childbirth, experiencing pain, there is no way whatsoever you could have given her a phone and say, can you just write me a little message about how painful this is, right? Not happening. So it's very important that we distinguish between the level of pain we are in objectively and the amount of which is bothering you. I understand that if you've got back pain, if you've got sciatica, it will be the one thing that's on your mind at all times, often. It is, if there's one thing, it's the thing that's bothering you the most. But objectively reporting and recording the level of pain that we're in is really important. When we say, I don't move, I'm stuck in bed all the time, that might well be true, or it might well be kind of true. We're probably getting out of bed to go to the bathroom. We've probably gotten out of bed in the last 24 hours at some point. And so that's important information. If we are sincerely have been stuck in bed, we're soiling our own bed, well, that's a different, like, we're on the wrong platform here. We should be calling someone to come and help us out, right? We should not be on social media talking about it. I don't mean that to say don't talk about it. Get help right now. But a lot of times we've been bedbound, we've been struggling to get out of bed, but we've been doing it anyway. And that is something that we can work with. That's something we can work with. You say, right, okay, we lie in bed, let's work on engaging the core. If you get out of bed by trying to do a sit-up or wriggling or this, that, the other, then we're making it harder for ourselves. We get people say, I cannot get out of a chair without pain. And then you look at them and they're getting out of a chair by doing this, right? And you can, in the moment, you can just teach them, get your feet underneath you, engage, brace, look up, and then come, and they go, wow, I've got no pain. So the person that feels like they're stuck in bed, anything they do causes them pain, a little bit of education can almost instantly sometimes result in them being able to actually just get out of bed without pain for the first time in maybe a long time. And now all of a sudden they don't feel like they're necessarily as bedbound, but the habits still kick in, so they still get out of bed regularly wrong the next time, and then, and then they feel like they're back to square one. But this is why education is so important. Don't give up. But education is so important to help you guys understand where you're maybe making mistakes. And if you are in bed, you can practice the core engagement. You've got nothing better to do. Practice learning to engage your core. Practice rolling onto the side. What else have we got to do all day, right? I say this to encourage you, not to chastise. Okay, I hope it makes sense. What can I do for marked lateral stenosis at L4-5 with disc protrusions, please? Everything we've been talking about. It's stabilizing the spine. It's learning to control this section of the spine, as I've just mentioned. Using simple exercises like we talk about, the core 5 all the time. Dead bug, marching bridge, squat, hip hinge, step up. Right? These teach you how to stabilize the spine, and they form the foundational exercises that you're going to use to build resilience back into the lumbar spine. Just coming back over to here, what have we got? Roy said, my PT told me that working on the glutes don't help my back problems. He said my glute weakness is a symptom. The glute weakness may well be a pre-existing factor, and they also will almost certainly be associated with the injury itself. But you're not working on your glutes when you do a squat. You're improving your squatting ability. It just so happens that you are working on your glutes, but you have an injury. You're learning to protect that injury through movements like the squat that just so happen to be able to work the glutes, the quads, the hamstrings, the core, the back muscles, etc. It's about the purpose of the exercise. The squat itself also helps improve your safety when, for example, you're getting out of a chair, as I've just mentioned. If you can do that correctly, you're not going to place your back under nearly as much strain every single time you're getting out of the chair, off the toilet seat, out of the bed, etc. Coding has said, can I feel pain without having a hernia pressing on my sciatic nerve? Yes, you can. I had surgery 2 years ago. Sometimes get leg pain, still comes and goes. Yes, because most of the time, people that have sciatica do not have the nerve being squashed up against the wall like it is right now on the camera. It's just contacting. Or maybe it's not even contacting. And it's maddening when people get this finding and they go, oh, you've got a disc bulge, but it's not even touching the sciatic nerve, so we don't know what's going on. It's like, come on, can we not be a little bit thoughtful, right? When you've got an injury, a significant injury, even if it's not touching the sciatic nerve, there's going to be inflammation around here in this small space. This small little space, and that can irritate. If congestion builds up around that area, that can irritate the nerves, and then we give rise to sciatic pain. It's also helpful to understand that you guys feel like the pain is going down the leg. The pain is not going down the leg. The brain, the signals that are being influenced, right? Muscle spasm and tingling goes down the leg, right? Because it's a motor pathway. Motor is the signals that goes to the, we've just got to fix that. There we are. Motor are the signals that go from the brain to the periphery. When we have the symptoms of sciatica, the numbness, tingling, etc., that is going from here up to the brain. There's nothing in the leg. There's nothing wrong with the leg. It's from the segment of the lumbar spine. It's irritating the nerves, sensory pathways that go up to the brain. And the brain thinks that those cables should be coming from the leg, which is correct. But they're being irritated halfway down. Now, I know when I bang my funny bone, boom, I know consciously that I just hit here. But I feel the symptoms here. The pain is not shooting down my arm. My brain just knows that that nerve that just got hit finishes in here. And so there must be something going on there because I'm getting tons of signals coming from that room or that part of the body. So understanding that is really important, right? Because you're talking about the leg, it's going to the leg. No, no, no. It's going from the back up to the brain, and the brain thinks it's coming from the leg. Hope that helps. Some of you guys, anyway. That'll be kind of a paradigm shifting way of understanding these things. Just scrolling through some more of the comments, guys. A said, thank you. Yeah, pelvic tucks. How many pelvic tucks do you have to do until it gets fixed, right? What's the plan here? What is the plan here? How are pelvic tucks, knee hugs, etc. going to be fixing your lower back pain? Explain the mechanism here. Oh, they're just moving the back a bit, okay? Oh, desensitize it or something like that. There is no mechanism for the pelvic tuck to build anything, right? It's just a movement, just like bending my arm. How is bending my arm improving anything here? It's not, is the answer. It's not. How is your squat improving? Well, your squat is going to go from this to this to this to this to this, if you're doing the squat correctly. As we mentioned earlier, that chart. So your squat starts with 0 weight and your squat ends on whatever your body weight is, 75% of that roughly for ladies in this particular case. So as you go along there, you have baked in improvement that becomes obvious. We had one of the guys last week talking about, I started to notice significant improvements when I got to 20 to 30 kilos on the squats. Things started to really click. Oh, symptoms starting to change. Why? Because you built resilience. You've changed the very structure of your spine. Your knee hugs don't do that. They don't do that. Neither do your pelvic tilts. You're kind of just wasting your time. And that's not at all your guys' fault, right? But always have one question in mind when you get told to do anything from your clinician. How is this helping XYZ injury improve its strength, resilience, etc.? Objectively speaking. And what measures are we going to use to grade the improvement outside of how I'm feeling? Very important questions, comments, things to think about. Always to ask. And your practitioner should have an answer to that question, right? Jackie said, one of my back problems is a pars defect at L3. Can you explain a bit about this, please? Pars is the area, pars interarticularis is the area in between the back part. So if we imagine this here, and then the body, like so, okay? When we are, it might be referring to a fracture, but it would generally give you more details there. What commonly this is that you have two ossification centers or a number of ossification centers in the vertebra. That means that the cartilaginous shell turns to bone and it spreads out. And where those two ends meet, there can sometimes be a defect where it's not quite fully fused bone. It's just a defective point. And so you commonly see that there might be an observation of a pars defect in an individual who, for example, might be in their teenage years, who doesn't have any slippage, but they have the pars defect there. And so it's been like that your whole life in most cases. Hopefully that makes sense. Cynthia said, hi Mike, I feel the chiropractor adjustment give me flares up. I'm behind in the rehab program. I also, new MRI shows right femoral zone and annular fissure and mild facet arthropathy with facet joint fluid. When we have an injury to the disc, you guys have to understand that the facet joint is on the back of that articulation. If I bend the vertebra in such a way, which we can see on this model here, if I bend it so the vertebral body moves and the disc articulation moves, the back is moving as well. So where we get degenerative change or injury at one area, we're going to have something going on at the other. It may not be significant, but in this particular case, it's notable. You want to understand what your chiropractor is actually doing, right? How are they approaching things? For example, if they're not doing something like spinal decompression on a big IDD table that's in the room behind me, or laser or something like that to the injured area, My general opinion is that you as a practitioner, so me being an osteopath working alongside chiropractors for more or less all of my clinical career, aside from when we had our clinic here in Cheltenham and in London. But prior to that, when I was working in other people's clinics, it was always with chiropractors and other osteopaths. Your chiropractor should generally be working on the upper lumbar spine, maybe the thoracic spine, maybe the neck, etc., because that's all they can do with adjustments, right? And some people feel that when they increase the mobility of other areas, they feel like it's just too much. They don't have muscular strength to deal with that extra mobility. If you're doing a lumbar roll, that one, crunch, maybe that's not the best choice of the technique, right? Because some of that's going to be going through the lower lumbar spine. As best as you might think, as much as you might think to the contrary, it's going to be. And that will probably be a bit of an issue. So I would be very careful with, if you're feeling it's not helping, I'd back off for a bit. Build a bit more strength and then go back to the chiro and see if they can help you once you've made a bit more progress on the program. That's probably going to be the best strategic option. Ultraviolet said, thanks, I'm a new member. Shane, awesome, Shane. I think if I manage to get around to it, I'll be talking about your x-rays today. We're going to go through them on Wednesday. I'll do a post in the on your post in the members area later today. So keep an eye out for that, Shane. Roy said, is the cat-cow and child's pose good before I start working out? No. No. What are we talking about here, guys? We're talking about spine stability. Hold this thing steady. So let's start off with some wiggling. No. Stability. Spine stability is what we're aiming for. Spine stability is the plan. What else we got here? And Roy, ROI Jungle, you've been on the program, you've been on some of these lives a couple of times. Go and check out the program. Right? You're doing other stuff. It's clearly not making progress. Check the program out. And to the topic of knee pain, a lot of you guys have weakness in the legs, right? You have weakness in the legs, which is arguably one of the reasons the lower back has been abused, right? Because your legs are weak, because you don't use them properly. You're always bending like this. Anytime you could have actually been using your legs to keep your leg muscles strong, you haven't. So now you've got knee arthritis, so you don't bend your knee so much, which is why you get in a chair like this and out of a chair like this, and you're abusing your lower back. Then when your lower back finally goes, you don't have the legs to compensate for the lower back being injured. And so it's par for the course that a lot of people will have some degree of knee issues, right? When you guys come to the program, when you guys start your rehab work, it's perfectly reasonable. And it's something that you need to manage as you go through the process. That's why we have support. Very, very common though, very common. Jay Manga said, I get a flare-up and dizziness when I hold a squat. Make sure you're not holding your breath. I don't know how long you're holding the squat for as well. Magdalena said, can exercises and the relief routine help with shoulder blade pain at the top of your shoulders? If you're getting shoulder blade pain up here, I would have a look at the Whiplash podcast. And there's a nice little neck relief routine that we've got. That might well be more coming from the neck than the actual shoulder blade itself. It's a very common referral pattern from a neck issue. So I would have a look at that. Starshine said, I'm having so much trouble with my left thoracic scoliosis. Lots of pain, especially in the lower ribs on the left-hand side. The muscles are going into spasm. Should dig back into doing the rehab work, right? Especially with things like scoliosis, especially in the thoracic spine, you're not straightening that out. We can't get onto that area to do anything. The best thing you can do is build up strength for the region, right? To support it better. That's what we need to focus on, guys. I think we're coming towards the end, guys, today. Just a reminder, we will be going through the live. I haven't gotten to talking about this, but I'm going to give it a little sneak peek. I think we'll wrap it up here. Guys, I'm going to go through a little sneak peek on this for Wednesday. And Shane, I will post a comment to you later on today in the members area. This was an image that we had, some x-rays. I've finished doing the analysis, some flexion extension x-rays. And this just highlights why I'm so against you guys doing forward bending stuff, right? The forward bending analysis, when your practitioner gets you doing forward bending, oh, you've got some good lumbar range of motion. You don't know how much the lower back is bending. You don't know how much L5, S1, L4, 5, etc. is bending. Unless, of course, we're lucky, like Shane is, to have the x-rays done, the flexion extension x-rays, then we can know when we realize that, hey, certain areas are moving and certain areas aren't. Across time, it's the same issue, by the way. We've got a flexion extension x-ray from 2024 and 2025, right? And we see very similar things, but one notable difference. So when we're standing up, we have a certain alignment, okay? I'm just going to use round numbers here because it just makes it easier for you guys watching. on Wednesday, I'll be sharing the images. So we've got a normal curve. Let's call it 100% of the lumbar curve in the neutral position. It's not quite, it's a little bit over, but for argument's sake. When we did the flexion last year, Shane looked like this, right? He'd actually taken his lumbar spine and gone like that. And he'd reduced his lumbar curve to around about 50%. So he had used a good amount of lumbar flexion, but he looked like he was still standing up straight. The next year, he does lumbar flexion. He starts standing up straight with almost 100% of the lumbar curve, and he bends forwards, and he looks like this. Now, you would be forgiven for thinking that his lumbar flexion has improved when he looks like this on the X-ray versus when he looked like this on the X-ray. Both images are flexion X-rays. Both images have a 50% flexion of the lumbar spine. But in the second image, that flexion, he had more coming from the hips. So one would be, if you were in a physical exam, the practitioner would say, this movement is significantly reduced lumbar flexion, and this one is better lumbar flexion. Yet on the measurements on the X-ray, they both show exactly the same, 24.4, wow, that's actually exactly the same, 24.4 degrees of lumbar flexion. One, he looks like he's actually bending over, the other, he's standing straight. And we'll see this next time. I don't know why I grabbed this chair instead of the other one, right? I look like a midget now. But it just goes to show, and we actually see that L45 and L5S1 hardly move. They hardly move. They move a little bit, but they hardly move. All this movement is coming from the upper lumbar spine. And it just goes to show just how poor a physical examination is of the lumbar spine. You don't know how much the lumbar spine is moving. So when you're doing your knee hugs, you're often either irritating a hypermobile, injured segment, or you're engendering more hypermobility into the lumbar spine. Where is it? We'll do that later. You're engendering hypermobility into the lumbar spine, as we will see here on Wednesday. So hopefully that's going to be helpful for you guys. Hopefully it makes a little bit of sense. I will go through and talk about this topic more next time. But thanks to all of you guys that joined. Hopefully that's been a helpful one. And if you guys need any more support, you can always check out the link in the profile page if you guys are over on TikTok. Those of you guys that are members of the program, please keep posting in the members area. We're there to help you guys across the next couple of days, couple of weeks, across the holiday season. And yeah, we'll be back for an earlier one on Wednesday, an earlier live session. Hopefully it's going to be helpful for you guys. Thanks so much for joining, guys, and we'll see you next time. Take care.